Welcome to the OncoloGIST, where we cut through the noise and get to the gist of cancer research straight from the experts. I'm Sabrina Sarania, and today I'm joined by Dr. Estelamari Rodriguez to talk about her top takeaways from this year's Targeted Therapies in Lung Cancer meeting. Let's get into it.
The unique thing about this meeting that is not only about kind of CME management of lung cancer, but really about the science and the new therapies and the small companies that are developing things. And so it's a really good, inspiring meeting about what comes next. Because we have had a lot of approvals in lung cancer. It's nice to see, people going over ROS and going over ALK and what's next and how the new drugs, the new generations of drugs are going to be better for patients with better CNS penetration, better toxicity profile. So it's nice to see the natural progression of targeted therapy, everything that people are doing to really push the envelope and get people to respond. We thought of personalized medicine as specific oncogenic-driven tumors, but as we're doing more in-depth NGS analysis, we're finding that patients can have multiple mutations, and there's very little research to understand the significance of co-mutations. We know that in EGFR, it can mean that you have more aggressive disease, and some of the new options to escalate treatment in EGFR, Mariposa trial and the Flora-2 trial are all about covering these other co-mutations and probably being more aggressive about them. Basically, like, how do we really combine different targeted therapies for people that have co-mutations, and how do we understand which co-mutation matters and how to follow them? I think that's becoming really poignant because we're finding them, and also we're able to monitor people with ctDNA in a way that we couldn't before, where we have patients on one treatment and we can follow the ctDNA of that mutation would go down and another one emerge. So I think that that's really in real time, that information requires research and guidance on what to do next. You can't talk about early stage lung cancer without having everyone in the room. So there was a radiation oncologist, there was a thoracic surgeon, Dr. Jessica Donington who's the chief of thoracic surgery at the University of Chicago, and then medical oncologists on board. So the discussion kind of started about, what are the surgical challenges for patients that we're now treating with neoadjuvant immunotherapy and targeted therapy. We have known now about 3 trials that use neoadjuvant immunotherapy. They all show very similar results in terms of improvements in pathologic complete response. But I think what Dr. Donington had to talk to us about is that there's a real delay and potential attrition to this neoadjuvant approaches for patients, so that they are patients that when they get chemoimmunotherapy, that delays their treatment at least 12 weeks. And then some patients do have attrition, like they have toxicity from that initial induction that doesn't allow them to get the surgery that they would have had. So I think there's a lot of nuance of patient selection and what is truly a surgical case and what is a patient that should go straight to surgery. So I think the delays to resection from the perspective of the surgeon was something that we heard about, not only from the provider patient perspective, that they were not able to get to surgery, but also like the provider lost RVUs because those patients didn't get to surgery, or they lost kind of the income that was going to be attached. People don't talk about it, but I thought it was a really interesting discussion. But in reality, at the end of the day, it's like if we lost patients that could have had a curative surgery. A lot of messages here were about picking the right patients, working as a team to carry patients through treatment. And there are patients that are not really good candidates for perioperative therapy and should go either straight to surgery or be offered chemoradiotherapy. And I think there's going to be a lot of more guidance to that. Then she also covered how, from the surgical perspective, we have the NeoAdora trial that is neoadjuvant or perioperative osimertinib in EGFR-positive lung cancer, and that's a positive trial showing an improvement in responses before surgery. But we also heard about the Alina trial and a press release of the Libretto trial looking at RET inhibition in the adjuvant setting and ALK inhibition in the adjuvant setting for those patients. And what was really interesting is that he presented data from a survey asking surgeons how often you get this information at the time you meet a surgeon is there's reflex testing. And in that group of surgeons that were interviewed, only about 60% of providers said that there was reflex testing, that they had this information before surgery. And for patients that came in with results that you can act on, only about 46% of patients had that information before you met them. So it kind of became a really practical discussion about, we have all this science about how we can optimize care for patients, but we may not have all that information up front. Getting that information means delays in care, and we have to get better at doing that. So I thought that was a really excellent discussion from the perspective of the surgery. The other discussion that I thought was really pivotal is really a discussion about using ctDNA for MRD testing. Dr. Dio presented that from Stanford, and he's been leading the way on trying to find ways to get ctDNA technology to the point that we could use it in real practice. And I think at the end of the day, what he had to share is that the technology is there. We don't have the data prospectively to make decisions, but we are definitely seeing trial after trial showing that ctDNA can be prognostic, so that patients that clear the ctDNA do better, that it can guide your surveillance for the patient, because if a patient is not clearing DNA or has minimal residual disease, there's a very high likelihood of recurrence. I think the next step is going to be how to kind of pair that information with the next treatment option for patients and when you can act on it. And I think there is definitely more research, and there are various trials going on that space. The immunotherapy discussion by Dr. Gensler had to do with updates on neoadjuvant and perioperative. So I think we've seen survival data from KEYNOTE-671. So I think everybody agrees that for patients with locally advanced disease who are surgical candidates, that's the way to go to offer them perioperative therapy. I think there's a lot of questions about if patients have a complete pathologic response, do they require more adjuvant immunotherapy? And there are national trials that are trying to answer those questions for patients. So I think I really call here for us to keep investing on trials that will kind of expand on what we know already. There's the Alchemist trial, was a trial looking at upfront adjuvant therapy, where it's sequential IO or concurrent IO. And for the perioperative questions, the SWAG 2414 trial is for patients that had a path CR that will be randomized to durvalumab or surveillance. And that's a really important trial because we could be over-treating patients and exposing them to toxicity that we'll learn was not required. Unfortunately, there was a trial that the ECOG Akron group had for non-pathologic complete response rate that is no longer open. So we definitely have a need for escalating treatment after patients go through surgery and they already had been exposed to chemoimmunotherapy and they have still persistent disease. We discussed that some of these patients may have actionable mutations that probably need to be targeted, but some may have a primary resistance to immunotherapy or chemotherapy, and the adjuvant setting, the treatment needs to be escalated, and the current trials just gave patients immunotherapy. So I think that was kind of more data for what to come next. And then there were some hints of what we should do next. There was a nice discussion on antibody drug conjugates with TROP2 inhibitors and others that could potentially be an answer to use in the perioperative setting, because those are drugs that deliver chemotherapy in a more precise way. And there's some international trials that will take some time to read out, but are really important because we could definitely bring some of the newer treatments in the metastatic setting for the perioperative setting. So that was a great discussion. And then I was part of a tumor kind of panel talking about different questions from providers about what to do. And you always learn that even when you get experts in the room, there's a lot of gray areas about what to do for patients, and that if we had trials, we can answer them. I think some of the questions that our group got, what to do about patients that go through preoperative chemoimmunotherapy and have significant burden of disease. And we learned from the radiation oncologists that there might be an opportunity, and there's an ongoing trial on the works that will offer radiation as a local therapy for those patients. But I think at the end of my discussion, we just basically learned that, especially in this early stage disease, moving therapies that work well up front. We learned that from immunotherapy. We're learning that from targeted therapy, one targeted therapy at a time. We have data for EGFR, we have data for ALK, we now have data in press release for RET inhibitors. So all of that data will be very helpful. And there are other targeted therapies that we're not even touching yet. HER2 MET exon 14 skip mutations. So there's a need for doing those trials, and maybe they don't require a large phase 3 trial, but at least some data to demonstrate that targeted therapies can play a role in the early stage setting, and that patients don't have to wait 10 years for those answers of those trials. I think the TROP2 inhibitors and other antibody drug conjugates that are being tested in the metastatic setting is good to see that they are being also tested in the perioperative setting, because we are going to learn that perhaps some patients will not need as much chemotherapy as we had done in the past, and we may move away from cisplatin, which is such a toxic drug to use in the adjuvant setting. So I think it was a great session, very multidisciplinary discussion about, and the kind of discussion that we have in our own tumor board at the University of Miami, and many of the doctors that were speaking come from big institutions where you could have these discussions in the same room with everyone. But we do realize that in the community, these discussions are very are difficult to have, because you have providers that are not meeting at the same time. They don't have a tumor board at the same time. So really, how can providers in the community have these discussions, and how important it is to involve all the members of the team, as difficult as it is, because it will really give patients better options and better outcomes.